All right. Assalamu alaikum, everyone. I'm Bushra. I'm an intern, and today I'm going to be giving you guys this session on nephrology practice questions. I've linked my phone number and my email in the beginning of the entire presentation. If you have anything at all you want to discuss with me, you have any questions before your exam, you can feel free to reach out. And yeah, if there's any question you have while I'm discussing, you can feel free to stop me, or we can talk about it at the end as well, whatever you prefer. So I want to first go over acid-base disturbances. I know this is a little bit of a difficult topic for you guys. What I'm going to do is I will go over Dr. Khalid's examples, the ones that he's given in his presentation. And I've added a few more. So like by the end of it, you're definitely going to be masters at solving the equations. Next, I want to discuss nephrotic a little bit, just like a brief overview, sort of, just to refresh your concepts. And then lastly, we'll go over the practice questions. Okay, first topic, acid-base disturbances. Let's just quickly go over how do you tell what exactly acid-base disturbance you have, and then we'll move over to the equations. The first thing you have, the first thing you need actually is an ABG. Now, an ABG is an arterial blood gas. This is basically a sample that you take from the artery itself. The most common place would be the radial artery. This is not from the capillaries, this is not from the veins, this is from the arteries, and that is why the PCO2 and the PO2, those are very accurate because this is arterial. You know, none of the oxygen has yet gone to the organs. So the first thing you would do when you have an ABG sample is to evaluate the pH. Now, the normal pH ranges would be from 7.35 to 7.45, right? So anything less than 3.5 would be acidosis. Anything over 4.5 would be alkalosis. First thing, look at the pH. Now, let's assume that our pH is low. What are you going to do next? You're going to look at PCO2 and bicarb. Now, what PCO2 amount would give you acidosis? When PCO2 is very high, right? So a high PCO2 would give you respiratory acidosis, whereas a low bicarb would give you metabolic acidosis. Why does the PCO2 being high matter? Because when you have more carbon dioxide in your blood, it reacts with the water in the blood, in the plasma. It forms carbonic acid. That's acidotic, right? This is acidotic, and so you have respiratory acidosis. And for bicarb in itself is alkaline or basic. When you have less of that, you have metabolic acidosis. Kind of makes sense. Once you've figured out that, you know, this is your primary disorder, what we do next is look at the compensation. Whether or not the opposite thing, so in this case, whether or not the bicarb, because that's the opposite, right? Whether or not this has increased. If there is an increase, there is very obviously a compensation. And in this case, it would be metabolic. If you were to have metabolic acidosis, you look at the PCO2. If it's decreased to a certain extent, you would call that respiratory compensation. Now, another thing that I know that your batch is particularly confused about is Winter's formula and anion gap, like that sort of stuff. We'll go over that in detail, but basically, anion gap is only important when you have metabolic acidosis. In any kind of acid-base disturbance, be it respiratory acidosis, alkalosis, whatever, it's not important for any of those other than for metabolic acidosis, okay? You would calculate the serum anion gap, which would be sodium minus chloride, and this should be minus, so minus bicarb. This is how you find out the anion gap. Now, if the anion gap was to be high, over 12, you would think about mud piles. I think Dr. Khalid went over another one for you guys, but they're pretty much both the same. They talk about the same exact things. So mud piles would be like methanol poisoning, uremia, diabetic ketoacidosis, aldehyde, we have iron, we have isoniazid overdose, which again, this is a little bit complicated, but again, just it would be nice to know if there was a question to come from this. The question itself has to be simple for you to figure out which kind of mud pile it would be. So lactic acidosis, most probably the most common kind of lactic acidosis question they're going to give you is somebody who, so one of the ones is like somebody who is post-op, they have hypoxia, you know, their oxygen saturation is low after the operation. And now it would make sense that they have lactic acidosis because they have anaerobic glycolysis, right? Ethylene glycol poisoning. In case of methanol or ethylene glycol, they're going to say something in the question stem like he drank a huge amount of XYZ. Like it's going to be some sort of a poison, some sort of a toxic substance. They're going to mention that. And then salicylates. This is aspirin. So aspirin overdose will lead to metabolic acidosis. It's late. In the beginning, you have respiratory alkalosis for aspirin poisoning, and then afterwards, later on, you have metabolic acidosis. But that's not very important for you to know at your level. And then lastly, if you were to have a normal anion gap, anywhere from 6 to 12, you have this mnemonic, which this one is not nearly as important as mud piles is, so I like definitely recommend you memorize these. And lastly, we have alkalosis, pretty much the same sort of thing with this, where you look at the PCO2 and you look at the bicarb. If the bicarb is high, metabolic, if the PCO2 is low, respiratory. I feel like all of this is getting a little bit redundant, so why don't we just quickly go over actual practice questions. Before we do, let's talk about compensation. So I know this is from your slides, and I would recommend that you memorize this, although I'm pretty certain that at least the respiratory is like not very likely to come, but I'm gonna go over this regardless. We need to make sure that you're as prepared as possible before the exam. So yeah, I just need you to make sure that you've memorized all of these formulas, okay, for the metabolic acidosis. This one isn't very accurate. We're instead going to use Winter's formula. So remember how we said metabolic acidosis is the only place where you really use anion gap? It's also the only place where you use Winter's formula for compensation, right? Metabolic alkalosis, 0.7 times. Anyways, blah, blah, blah. We're going to do practice questions and you're going to understand. I will join from my iPad so that we can do the questions together. Give me 1 minute. So this is the first example. So this is the first example, and the first few examples are from your slides. And so I just wanted to go over them because I know I looked at the transcription, it seemed a little bit difficult. So what we're going to do is we'll quickly go over a few examples from there, and I've added a few as well. So this is the first one we have. As I mentioned earlier, the first thing you do is look at the pH. From the pH, we can tell this is too bad, honestly. Anywhere from 35 to 45 is considered normal, and bicarb anywhere from 22 to 26 is considered normal. So the PCO2 is almost okay. The bicarb is quite low, so this would be metabolic acidosis, right? The moment you have metabolic acidosis, the next immediate step, I've listed the examples here as well, the steps, sorry. The next immediate step would be to measure the anion gap, okay? What is our anion gap? Sodium minus chloride minus bicarb, okay, which is 130 minus 100 minus 10. And this should be 20. Okay, this should be 20, which is much greater than 12, which means that we have a high anion gap. So far, according to our example, we have metabolic acidosis, but with a high anion gap. What is the next step? The next step is to look for whether or not we have compensation. So we can either have compensation or we can have a concomitant or a secondary disorder. Let's look at the formula. The formula for compensation for metabolic acidosis, as I mentioned earlier, is Winter's formula. Now, what is that? 1.5 times bicarb plus 8 and then plus minus 2. Okay, so 1.5 times 10, which should be 15, plus 8 plus minus 2. So 23 plus minus 2, and the range that we would get would be 21 to 25. This is what the expected PCO2 amount is supposed to be. But that's not what this is. If you go back and look, our actual amount is actually 35. 35. And 35 is so far off from this, which means that this is not compensation anymore. We most probably have a secondary disorder, right? Okay. Moving on to the next part. Oops, sorry. Okay. Moving on to the next part. Once you talk about compensation, the next thing is to look at your baseline. So we're going to calculate our baseline bicarb because what we want to know now that we know that there's two separate disorders, we want to know, was there something going on before this entire thing even started? Which means that before you got your metabolic acidosis, alongside this would be respiratory acidosis. And why is this respiratory acidosis? Because our PCO2 is 35. Our PCO2 35 is higher than what the range that they've provided, or the one that we've calculated, 21 to 25. When this is higher, PCO2 being higher, of course, this is not compensation. This is not normal anymore. We have a secondary disorder, and in this case, it is respiratory acidosis because the PCO2 is higher than what it's supposed to be. Does that make sense? Okay, I'm gonna assume that it does, and then I will move on. All right, sorry. Okay. So the next part of it is calculating our baseline bicarb, which, as I mentioned earlier, we want to make sure that we want to know whether we started with a completely normal acid base or completely normal pH, or did we start off like before this metabolic acidosis even occurred, was there something else going on? So a baseline bicarb, the formula to measure that would be measured bicarb plus the change in anion gap, right? So before this, we calculate the change in anion gap, which our anion gap was 20 minus 12, and the change or the delta Ag would be 8. Okay, so our measured bicarb in this situation is 10, and 10 and then 8 would be 18. 18 is nowhere near 24, and 24 is what the normal bicarb in our body is supposed to be. It's nowhere near close to that, which means that we already had some sort of an abnormality or some sort of an acid-base defect before the metabolic acidosis even started. Because the bicarb in this case is less, we would assume that a lower bicarb would mean acidic. And so this would be metabolic acidosis. A baseline, we're going to call this a baseline metabolic acidosis. And then the last step of this would be just to confirm all of this by the delta delta. So the delta would be the delta, or delta basically means change. So a change in anion gap divided by a change in bicarb. The change in anion gap, as we calculated earlier, was 8. The change in bicarb, the normal amount should be 24. What we have is 10. So 24 minus 10, which would be 14. And then I think this was like 0.57 or something. And any value that is less than 1 shows us that there is a concomitant high anion gap metabolic acidosis alongside a non-anion gap metabolic acidosis. So now I'm just gonna sum it up for you guys. So initially we started off with the fact that there was a metabolic acidosis, right? We already have the acidosis. We were trying to calculate the compensation, right? And then we figured out this is what the compensation was supposed to be, 21 to 25. Our PaCO2 of 35 is much higher than what's given. And so we're thinking of a concomitant respiratory acidosis, right? And then when we looked at the baseline, that sort of showed us that there was also some baseline abnormality going on for this. And so there is here a baseline metabolic acidosis as well. So to sum it up, yes, this is quite difficult, but to sum up the entire thing, we have a high anion gap metabolic acidosis, which is right here, with non-compensated respiratory acidosis, which is what we calculated here. And then there's also a pre-existing baseline metabolic acidosis. So this is basically what is going on with this question. It's a little bit difficult, I know. And I think this is the hardest, I think, out of all of the other questions. The other ones are relatively easier, alhamdulillah, but we're pretty much going to go over them as well. All right, moving on. So first step, look at the pH, 7.52. That's quite high. We're thinking alkalosis, right? Okay. Next, we look at the PCO2 and the bicarb. We want to know what is causing the alkalosis. Is this respiratory? Is it metabolic? So we're looking at the PCO2, which is lower than normal. Can a low PCO2 cause alkalosis? Yes, it can. So this is respiratory alkalosis, right? And then we look at the bicarb. The bicarb is slightly elevated. The baseline is 24. So what are we thinking? Just 1 second. Okay, we're not thinking anything right now. What we want to do next is look at the compensation, right? So next step would be to look at the compensation. What is the formula for compensation for respiratory alkalosis? First of all, I've already mentioned in the question that this is acute because there's different formulas for acute and chronic, and it will most likely be given in your question stem. Whether this patient's been having a chronic issue, this patient's been having an acute issue. 3 months is sort of the no, not 3 months. Sorry, that's something else. But basically, yeah, they're gonna tell you whether this has been going on for a few days, versus if the patient's been having this issue for a couple of weeks or months, and that's when you sort of can differentiate between acute and chronic. So for compensation, acute respiratory compensation, we use the formula change in bicarb is equals to 0.2 times the change in PCO2. And why are we doing this? We want to look at the expected amount of PCO2 decrease, because the bicarb decrease, because technically the bicarb should decrease, right? If we have respiratory alkalosis, the most it kind of makes sense for us to have a decrease in bicarb so that the alkalosis can go towards normal, or there can be some sort of compensation. So let's quickly substitute the formula here. What's the change in PCO2? The normal PCO2, we would expect it to be 40. The change would be 40 minus 24, which is 16. So 0.2 times 16, which the answer to that is 0.2 times 16. 3.2. Okay, so this is the change that we're expecting. Now, if we already have respiratory alkalosis, we're expecting the bicarb to go low, right? So 24, again, this is delta. Delta means change. The change is 3.2. So 24 minus 3.2, because we're expecting a decrease, would be close to 21. 21, sorry. Right? We're expecting it to be 21. It is not 21. The actual bicarb is 27. It's actually much higher than 21. That means that this is not compensation. This is a whole separate disorder on its own. So not only do we have respiratory alkalosis, we also have concomitant or not pre-existing, but also we're gonna have metabolic alkalosis. Okay, so this is respiratory alkalosis with metabolic alkalosis and acute in this case. Yep, that's pretty much it. Let's move on to the next question. Okay, first step, look at the pH. The pH is normal, which is actually quite weird, right? But yeah, it is normal. The PCO2 is almost normal as well. Anywhere from 35 to 45 is considered normal, but again, it is towards the higher end. So yeah, it's kind of normal. The bicarb is quite elevated, right? So from the elevated bicarb alone, we can kind of look at it as a case of metabolic alkalosis. Okay, when we have metabolic alkalosis, we can now sort of calculate the compensation. What is the formula for compensation for metabolic alkalosis? It is change in PCO2 is equals to 0.7 times change in bicarb. Okay, so let's calculate that. 0.7 times the change in bicarb, which the normal bicarb is supposed to be 24. The change is going to be 6. Okay, 0.7 times 6. Let's look at what that's going to be. 4.2. Okay, now we have 4.2, and this is the change in PCO2. Now, if you have metabolic alkalosis, should the PCO2 increase or decrease? The normal baseline is going to be 40, right? And you would expect the PCO2 to increase, go towards acidosis, so that we make the pH sort of normal, right? So when we do that, we're going to add. The answer is going to be 44.2, which the answer in the question is 44. 44.2 and 44 is very, very close. And so what we're going to consider this is compensation. This is compensation. So we have metabolic alkalosis with compensated respiratory acidosis. And that is exactly why our pH is normal. Our pH is normal, even though there is an underlying abnormality. The respiratory system is working so well where we're able to normalize the pH pretty much. All right, next question. Okay, so first step, look at the pH. What is our pH here? Acidosis, okay? Next step, figure out what is causing the acidosis. Is it the PCO2? Is it the bicarb? The PCO2 in this case is decreased. The bicarb is also decreased. So a decreased PCO2 is not going to cause acidosis, but a decreased bicarb can cause acidosis, which is why this is metabolic acidosis. Whenever we have metabolic acidosis, next immediate step, anion gap, okay, which is equals to sodium minus chloride minus bicarb. Okay, sodium in this case is 130, chloride is 110, and then bicarb is 10 as well, which means our anion gap is 20. Okay, once you have the anion gap sorted out, let's look at the compensation. What is the formula for compensation of metabolic acidosis? It's actually Winter's formula, right? What is Winter's formula? It is 1.5 times bicarb plus 8 plus minus 2. Okay, so 1.5 times bicarb, which is 10, is going to be 15 plus 8 plus minus 2, which the range is going to be 21 to 25. Okay. Is our bicarb anywhere in this range? Yes, it actually, or PCO2, sorry. Is it anywhere in this range? Absolutely it is. It is 24, which is very close to this. So we can consider this to be compensation. There is no other concomitant disorder, at least respiratory, because our PCO2 is within the range that we calculated by the formula of compensation, which is Winter's formula. So far, what do we have? So far, we have a high anion gap, okay, metabolic acidosis with respiratory, with compensated, not just, with compensated respiratory alkalosis. Okay. And that's it. Pretty much, yeah. Hold on. Let's look at the anion gap. I think I made a tiny mistake. Okay, that's totally on me. So basically, the anion gap is actually not 20. It's actually 10 because this is 130. So 130 minus 110 minus 10 would be 10. And this is actually normal anion gap metabolic acidosis. So pretty much everything else in the formula has stayed exactly the same. Yes, there is still compensation, but the only difference now is that there's normal anion gap metabolic acidosis. And when you have a normal anion gap, then you would not do the delta delta. It's not necessary anymore. Yeah, and that's pretty much it for this question. Okay, how many questions do we have? We have 3 questions left. For this question, I will give you guys 2 minutes to solve this on your own, and then we'll go over it together to see and to correct and see like what you guys have done. This is a good opportunity to test yourself. Bismillah. And see if you're able to follow along. Okay, if everyone's done this on their own, we can talk about solving this. All right. So the first step is looking at the pH, right? The pH is severely acidotic here. So we have acidosis, respiratory acidosis. Now we look at what exactly is causing the acidosis. So this is the PCO2, this is the bicarb, right? The PCO2 is very, very elevated, so it makes sense for it to be respiratory acidosis. Okay. And the bicarb is decreased. And a decreased bicarb is also sort of feeding the acidosis. And this would be metabolic. So the fact that the PCO2 and the bicarb both point in the same direction already gives us two different disorders on its own right now. So not only do we have respiratory acidosis, we also have concomitant metabolic acidosis, right? The fact that we have metabolic acidosis, we can go ahead and calculate our anion gap, which is going to be sodium 145 minus chloride 102 minus bicarb 18. Let me calculate this really well. Hold on. The answer would be 25, which is elevated, which is very severely elevated. So we have a high anion gap right here, okay? The next step about, once you have metabolic acidosis, first step, anion gap. The second step, compensation. Compensation would be through Winter's formula. So this is our Winter's formula. 1.5 times bicarb plus 8 plus minus 2, okay? 1.5 times the bicarb is 18 plus 8 plus minus 2. Let me use a calculator real quick because clearly I'm struggling with the maths. 27, hold on. Sorry, 27 plus 8, 35 plus minus 2. And the range would be anywhere from 33 to 37. This is our range. Now let's look at the PCO2. Is it anywhere in this range? No. Our PCO2 is 62. Our PCO2 is 62, which is so much higher than what's given in the formula right here, which means that this is not just compensation anymore. There is a concomitant disorder, but guess what? We sort of already knew that because we know that we already have respiratory acidosis with a high anion gap metabolic acidosis, right? Now what we're going to do is we already know about the two disorders. Now we want to know about the third one. We want to know whether or not there was something pre-existing before all of this even began, right? So actually, no, let's talk about baseline. So baseline bicarb is going to be measured bicarb plus the delta anion gap. The delta anion gap in this case is 13, right? So the measured bicarb is 18 plus 13. This is 31. Baseline is 31. Now, 31 is so much greater than 24, right? Which means we already had a pre-existing disorder. And what was a pre-existing disorder? When the bicarb is elevated, this would be metabolic alkalosis, right? So let's write that down, metabolic alkalosis, okay? And lastly, we're going to do the delta, which is equals to the delta AG, or the change in anion gap over the change in bicarb. What's the change in anion gap in this situation? We already calculated it. It's 13. What about the change in bicarb? This is going to be 24 minus 18, which is 6. Right? Yeah, it has to be 6. Okay. 13 divided by 6 is going to be 2.2. And every time the delta is more than 2, shows us that there are two different concomitant disorders going on, right? So if we were to talk about this entire, this patient's entire thing, let's just quickly sum it up. So this patient very obviously has respiratory acidosis, as we measured earlier, alongside a high anion gap, metabolic acidosis with baseline metabolic alkalosis. And the more than 2, the fact that it's over 2, sort of just reconfirms the fact that, yeah, there was a pre-existing disorder going on. And in this case, that was metabolic alkalosis. So there's 3 different disorders going on in this equation right here.
Okay. Now let's go over, just have 2 more questions left. Let's go over this. This one is one that I've put in from my side. The first couple were from Dr. Khalid. Okay. First step, pH. pH 7.3, acidosis, right? Second step, cause of acidosis. Is it the PCO2, which is low? No, I don't think so. Is it the bicarb, which is low? Yes. Metabolic acidosis. We have another metabolic acidosis. All right. Look at immediately the anion gap, which would be 141 minus 102 minus 14. What is that? Okay, 141 minus 102 minus 14. 25. Very, very, much more than 12, so also grossly elevated, right? Move on to compensation. Winter's formula, 1.5 times 14 plus 8 plus minus 2. Okay, so the range is going to be 27 to 31. This is the range. Look at the PCO2. Is the PCO2 within this range? It actually is. It actually is within this range. What does that mean? If the PCO2 is within the range that you calculate by the Winters formula, this means that we have respiratory alkalosis, and this is just compensation. This is not a concomitant or a secondary disorder. So I'm just going to write this as compensated respiratory alkalosis, right? Next we look at the baseline to know if there's any baseline disorders going on. Right, so this would be baseline bicarb, which is measured bicarb, right? We're measured bicarb plus the change in anion gap. The measured bicarb was 14 plus the change is 13, which this equals to 27. 27 is more than 24, so we would say that there was a pre-existing disorder going on, and in this case this would be pre-existing metabolic alkalosis. Okay, perfect. And then we can just quickly do the delta just to make sure. Is equals to Ag over delta bicarb, which the delta Ag we calculated was 13. Or let's just quickly go over it. Why is it 13? 25 minus 12. 25 is what we calculated, and then 12 is the normal anion gap. This is going to be 24, which is the normal, minus 14 is what we have, and this would be 13 over 12, which is 1.3. The fact that it's 1.3, which is not greater than 2, means that, hold on. Oh, sorry there, hold on. Oh, sorry. I just had a brain fart. But let's just quickly go over this. So yeah, so basically we have a high anion gap, as we know from the 25. We have a high anion gap metabolic acidosis. So that's the primary disorder that we have, right? The fact that we have the compensation is within the normal, then within the calculated, means that we have a with a compensated respiratory alkalosis, right? And then we measured the baseline bicarb, and the baseline bicarb ended up being 27, which is higher than 24. And so there is a pre-existing metabolic alkalosis as well. So yeah, while there's just two disorders here. The primary being metabolic high anion gap metabolic acidosis. There is compensation, which is good, and then there was a pre-existing metabolic alkalosis, which is before any of these disorders even occurred, which is before the primary disorder even occurred. So okay, let's move on. This is our last question. Once again, we look at the pH. This is acidosis. Please don't be metabolic. I'm sick of that. Looks like it kind of is metabolic. Yeah. I guess metabolic disorder is just acidosis is just the most common, and that's the one that you'll be tested on the most. So it's good that we're going over tons of these So make sure that you're really an expert in this. And if you look at the PCO2, it is completely normal. Now, the moment you have metabolic acidosis, we look at the anion gap. Once we look at the anion gap, that would be 131 minus 94 minus 12 minus 94 minus 12 is 25. Not again. 131. Is that right? Mm-hmm. Yeah, yes, that's right. Okay. What's next? Now we look at the Winter's formula for the compensation. We want to know whether or not there's any compensation. Winter's formula is 1.5 times pi curve, which is 12. The answer is going to be 18 plus 8 plus minus 2, and this is going to be 26 plus minus 2, which would make the range anywhere from 24 to 28. Is our PCO2 within this range? No, it is not. Our PCO2 is actually 40, which is very much greater than the range provided here, which means that we do have a concomitant disorder, and in this case, it is respiratory acidosis. Okay, and then once we have that, you look at the baseline, right? Or the delta. First baseline, to calculate the baseline bicarb is the measured bicarb, which is 12, plus the anion difference in anion gap, which would be 13. In this case, this is 25, which actually is very, very close to 24. So in this case, we can honestly consider that it is 24. It's almost the baseline. The baseline bicarb is very similar to our regular bicarb, and we can say that this is there is no pre-existing condition. No pre-existing condition. All right. Perfect. And then the delta is not necessary in this condition. So basically, the only two things that we have here are the metabolic acidosis with a concomitant respiratory acidosis. And before you say metabolic acidosis, this is a high anion gap. Okay, high anion gap metabolic acidosis alongside concomitant respiratory acidosis. And that's pretty much it. That's all for the questions. There was a lot of metabolic acidosis, I know, but I think it's really beneficial for us to have. This is most probably what's going to come. This is what came for me. None of the other ones came. I think this is the Winter's formula is for sure going to come on your exam. So make sure that you go over it really, really well. And for metabolic acidosis specifically, I've provided this sort of rule book, you can call it, this order of steps that you can follow to very easily come to your answer. All right, that's it for the practice questions in terms of acid base, and now we can move on to the rest of the questions.
This account? Oh, okay, perfect. So I'll just continue where I left off. This is where I left off. Again, I would want to re-emphasize the importance of these equations. Again, not necessarily the last four. I think the first two are more important, and even more than that, metabolic acidosis. I wouldn't recommend you use this formula. Use Winter's formula, which is 1.5 times bicarb plus 8, and then plus minus 2. All right, so this is the question in action. Okay, this is the kind of questions that you'll get, and they'll most probably have an entire physical, like an entire scenario. You'll get the pH, you'll get the PCO2, the bicarb, and then they will tell you to calculate. So let's sort of go over this together, okay? A 70-year-old woman is brought to the emergency department by her daughter because of a 2-day history of non-bloody diarrhea. The patient has had 8 to 10 bowel movements daily, has not vomited. She has a history of hypertension, coronary artery disease, hyperlipidemia, type 2 diabetes. Current medications include all of these, blah, 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 blah. Not very important. She appears ill and sleepy. She is of this height, this weight, and her BMI is 44, which is very high. Her temperature is slightly elevated. She is febrile. Her pulse is high. Her respiratory rate is not too elevated, and the blood pressure is perfectly fine. Pulse oximetry shows an oxygen saturation of 97%. Physical examination shows dry mucous membranes. A fingerstick glucose test shows no abnormalities. This means whenever they give you an acid-base disorder and they tell you that the glucose test is normal, we're immediately ruling out diabetic ketoacidosis. Because in someone, in an older female who has diabetes, this is one of the things that we can think about. Not when they have type 2. Diabetic ketoacidosis is very common when they have type 1. And so if you were to have a kid, a young adult who presented like this, and they say that this is negative, you're ruling out diabetic ketoacidosis. An ABG analysis shows a pH of 2.4, which is low, right? A PO2 of 85, which is also a little bit on the lower side, but it's not, it's definitely on the lower side. A PCO2 of 39, and then a bicarb of 16. And now they're asking you, what disorder is this? And do they have a concomitant disorder or do they have compensation? I will wait for your answers. So the answer is metabolic acidosis with respiratory acidosis. Now let's go over why exactly. First of all, the pH is low. It's acidotic, right? Step number 1, we know that there's acidosis. Step number 2, we want to know what's causing the acidosis. Is it the bicarb? Is it the PCO2? Let's look at the PCO2. PCO2 is 39. The normal is 40. So that's not very low, or that's not very high. The difference is not too much, so we're immediately ruling out respiratory acidosis, right? Next, we come to the bicarb. The bicarb is quite low. The normal would around be 24, and this is 16. It's quite low. So immediately, the first thought is metabolic acidosis. We can now rule out C. We can rule out A. Now we're thinking B, D, and E. Are we thinking respiratory alkalosis, acidosis, or compensation? How do we know this? We know this by the formula. Metabolic acidosis, we're going to use Winter's formula, right? So 1.5 times the bicarb. What's the bicarb? The bicarb is 16. 1.5 times 16 is 24, right? 24 plus 8 would be 32. 32 plus minus 2 would give us a range of 30 to 34. Let's look at the PCO2. Is it anywhere in between 30 to 34? No, it's not. It's actually 39, which is very, very elevated. So this is no longer a compensation, right? We're not thinking compensation, so we rule out D. Now we are stuck in between B and E. Is this respiratory alkalosis or acidosis? The PCO2 is on the higher side. This is not lower than 35. If anything, it's a little bit on the higher side. So we're thinking respiratory acidosis and not respiratory alkalosis. And so that is why it's E. Okay, a quick background on nephrotic syndrome. You can honestly skip this if you'd like. I'm just going to spend like 2-3 minutes on this, but something that's very important that I feel like a lot of professors don't talk about in detail. I'm not sure if it's still the case, but it was when I was in third year, is what exactly makes nephritic and nephrotic so different. So nephritic syndrome is basically a disorder of the endothelium itself. You know, it's a disorder of the endothelium. That is exactly, that's why you have, you know, the hematuria. That is why you have red blood cells, dysmorphic red blood cells specifically, because there's something wrong with the capillary. There's something wrong with the endothelium. Whereas nephrotic syndrome is more so a problem with the podocytes, right? The podocyte is more on the glomerular side, whereas the blood capillary is on the blood side of the entire glomerulus. So something like this, the podocyte, when these get damaged, or when the basement membrane gets damaged, that's when you're losing your charge barrier and your size barrier. And a charge barrier, basically they're negative. The basement membrane is negative in charge. And this is what helps keep the albumin or the negative proteins in. When you lose either the basement membrane or there's something that goes wrong with the podocytes, now you've lost your size barrier, you've lost your charge barrier. Now albumin can very easily escape, and that is what makes nephrotic nephrotic. Oh, one last small slide on nephrotic syndrome. We know that nephrotic is a decrease in the amount of protein, right? And how does that manifest exactly? I just wanted to have this one picture. I feel like this, if you know this picture, you know nephrotic thoroughly. Okay. So the first thing you're gonna have is proteinuria. Of course, you're losing the protein, you're losing it in your urine, and that's gonna give you frothy urine. It almost looks like beer. It's quite alarming for the patients, and this is one of the first things that they will tell you in clinic is that my urine is very bubbly or very frothy. The next thing you lose is antithrombin 3. So antithrombin 3 is also a protein, right? And it's a very important protein. It's necessary for the coagulation cascade, right? So when you lose for anticoagulation, basically. So when you lose this, you're at an increased risk of developing a thrombosis. Next, you are the amount of albumin in your blood is decreasing, right? When your albumin decreases, your liver senses that because liver is synthesizing albumin. When the blood levels are low, your liver is going to sense that, detect that. And the liver increases all of its activity to try to keep up with the albumin demands. And when you increase all of its activity, it also ends up producing more triglycerides, more lipids. And when that happens, you have your characteristic fatty casts or oval fat bodies which are present in your urine. Very characteristic of nephrotic syndrome. You have decrease in the number of immunoglobulins, which are also proteins, by the way, and that predisposes you to infections. You have decreased plasma oncotic pressure, which I'm sure all of this you already know. This is what causes edema. And when you have a decreased oncotic pressure, there's overall a decreased effective circulating volume because more volume is now extracellular rather than being intracellular. That decreases your GFR. The kidneys are going to activate the RAS system. You're going to lead to sodium and water retention, which is going to make the edema even worse. So this is sort of just a brief overview of nephrotic. This, by the way, is from Boards and Beyond, and I think this is very, very, very important before you look at the questions and before you solve anything at all. The last slide before we move on to practice questions is nephritic syndrome. This is an issue with the filtration barrier, right? What is the filtration barrier? The endothelium. So yes, you have proteinuria, and that's going to cause edema, but it's not going to be nearly as much as nephrotic. You're going to have a decreased GFR because, of course, the membrane that's filtering out all of the proteins, the endothelium is damaged, right? This is going to cause, when the GFR is low, you're retaining more urea, you're retaining more creatinine. You're not urinating as much because not a lot is getting filtered out. And when not a lot is getting filtered out, we have more fluid within the intravascular space. And this can lead to hypertension and edema considering the hydrostatic pressure is really high. One last thing is when the filtration barrier is not optimum, we're going to have red blood cells in the urine, such as casts, and also dysmorphic. What dysmorphic basically means is mishappen or like they're just weird shapes. And why would red blood cells be weird shapes is because they get forced out from the endothelium, the damaged endothelium, and when there's pressure, they're getting forced out. The biconcave disc shape will remain no longer, and they will get there's going to be a weird shape now. All right, moving on to the actual questions. Let's go over the first one together. So a 47-year-old woman comes to the physician because of a 2-week history of gradually worsening facial and lower extremity swelling. She has had a 4 kg weight gain during this time. Her blood pressure is 150/88. Examination reveals periorbital edema and 2+ pretibial edema bilaterally. A 24-hour urine collection shows 4 grams of proteinuria. Microscopic examination of the kidney biopsy specimen shows thickening of the glomerular basement membrane, and the electron microscopy shows dense epithelial deposits or spikes. Further evaluation is most likely to show which of the following. Now, first of all, we're immediately thinking of either nephritic or nephrotic. First of all, 4 grams of proteinuria, the weight gain, right? The facial and lower extremity swelling, right? All of these are pointing towards nephrotic. Now that we've thought about nephrotic, what next? What are the different kinds of nephrotic? Let's look at the electron microscopy. First of all, there's thickening of the basement membrane. And then we see dense epithelial deposits or a spiky membrane. This is very, very characteristic of membranous glomerulonephritis. So membranous, we know that if we have primary membranous glomerulonephritis, we know that anti-phospholipase A2 receptor antibodies are the ones that are most commonly associated with this. Let's sort of go over the other examples. This would not be anti-myeloperoxidase, anti-proteinase, antibody. Why? Because we're not suspecting any of the vasculitis. The small vessel vasculitis, we're not suspecting that, solely because this is mostly a kidney issue, right? This is mostly a kidney issue and it's nephrotic. So we're not thinking vasculitis. Anti-strep O antibodies, we're not, because that would also present as nephritic. That would be post-strep glomerulonephritis. We're not thinking of that. And then anti-collagenase type 4 antibodies, that would be good pasture basically. And there's nothing really going on with the lungs for us to say that this could be good pasture, right? And good pasture, to be honest, is also nephritic, not necessarily nephrotic. So the fact that all of these clinical findings leads to nephrotic really just solidifies why we think A is the answer. Okay, next question. A 48-year-old man comes to the emergency department because of a sudden right flank pain that began 3 hours ago. He noticed blood in his urine. Over the past 2 weeks, he's developed progressive lower limb extremity swelling with a 4 kilogram weight gain. Examination shows bilateral 2 plus pitting edema of the lower extremities, and a urinalysis with dipstick shows 4 plus protein, positive glucose, and multiple red cell and fatty casts. Abdominal CT shows a large right kidney with abundant collateral vessels and a filling defect in the right renal vein. Which of the following is the most common or most likely underlying cause of this patient's symptoms? Do you think this is factor V Leiden, or increased lipoprotein synthesis, loss of antithrombin 3, malignant EPO production, antiphospholipid antibodies? Okay, so the answer is loss of antithrombin 3. Why is that? Basically, when you look at the question, you look at the fact that there's blood in his urine, right? There is progressive edema in the lower limbs, and there is weight gain. And we have bilateral 2 plus pitting edema and 4 plus protein. The moment you see 4 plus protein specifically, because I feel like lower extremity swelling can be sort of borderline. Blood in the urine can also be a little bit borderline, although it's more nephritic for sure. But 4 plus protein is very, very characteristic for nephrotic, right? And the fact that you're seeing fatty casts is also leading towards nephrotic. So, yeah, so we're assuming that this is nephrotic. Now, why are we not saying, for instance, increased lipoprotein synthesis, and why is it loss of antithrombin 3? The fact that there is a filling defect in the right renal vein, filling defect should immediately tell you that there's some sort of a thrombosis, right? And a thrombosis would occur because of a loss of antithrombin 3, as I mentioned earlier. So really, the most important thing here is to know that the underlying cause for all of this is the nephrotic syndrome, and what's really causing, what part of nephrotic is giving you the presentation in this patient is the loss of antithrombin 3, which is giving us a thrombosis, basically, in the right renal vein. Okay. A 62-year-old woman with type 2 diabetes comes to the physician because of a 3-month history of fatigue and weakness. Her hemoglobin A1C concentration is 13.5, which is very, very high. The normal amount should be less than 6.5. Her blood pressure is also very elevated, shows lower extremity edema. Serum studies show this. We look at the potassium, it's normal. We look at the phosphorus, that's all right. Calcium is slightly low, but it's nothing alarming. The urea nitrogen is elevated, 20 is the normal, and the creatinine around 1 is normal. So these are both elevated, right? So we're suspecting some sort of a renal abnormality or a renal pathology. Which of the following is the most appropriate parameter for early detection of this patient's renal condition? So the fact that she has type 2 diabetes, we're suspecting diabetic nephropathy. What out of all of these is the first thing that you want to measure when you want to look at the degree of diabetic nephropathy? The urine albumin. So we're obviously not looking at the red blood cell count, right? That's more so nephritic. We're not really looking at the serum total protein. That's more nephrotic. Serum urea and creatinine are not very good prognostic factors or very used for detection of a nephropathy. The first thing that would occur is damage to the basement membrane or damage to the podocytes, and that would increase the amount of urinary albumin. So then really the first thing that occurs in diabetic nephropathy is albuminuria, And then after that, once, the nephropathy's been cooking for a while, that's when you would have serum creatinine and serum urine nitrogen elevated. That's not the first thing that would happen. And yeah, once you've had the urine albuminuria for a long enough time, that's when the serum total protein would decrease as well. But that's not the first thing that occurs. The first thing would be urinary albumin. All right, next question. A 69-year-old white man comes to the physician because of a 15-day history of fatigue and lower leg swelling. Over the past 8 months, he's had a 3.8 kilogram weight loss. He smoked cigarettes daily for 48 years. He appears thin. Examination shows 2+ pretibial edema bilaterally. An X-ray of the chest shows right upper lobe density. Laboratory studies show the following. So there's these. Light microscopic examination of a kidney biopsy shows thickening of glomerular capillary loops and the basement membrane. So now what are we seeing? We're seeing thickening of the basement membrane and the glomerular capillary loops. If we were to look at the laboratory studies properly, hemoglobin is a little bit decreased, but it's like not alarming. Leukocyte is fine, platelets are a little bit low. The urea nitrogen is slightly elevated, the glucose is perfectly fine. Creatinine is a little bit elevated, but not too bad. Albumin is really low. So the normal albumin is anywhere from 3.5 to 5.5. So we can see that it's very low. Total cholesterol, max, the upper limit is 200. So 480, super high. So the combo of a higher cholesterol with a lower albumin together, immediately we're thinking nephrotic, right? Next, there's no glucose in the urine, but there is protein and there's numerous fatty acids. So once again, we're thinking that this patient has nephrotic syndrome, right? And there is basement membrane thickening. Which of the following is the most likely diagnosis, do you think? It's E, it's membranous. Now, why is it membranous and why is it not any of the other kinds? Rapidly progressive or crescentic glomerulonephritis would include. Okay, so it would include anti-GBM, in which the patient would have hemoptysis, right? This patient doesn't really have hemoptysis, so we're not really thinking of that. Rapidly progressive would also include these two. So it would be granulomatosis with polyangiitis. It would be membranoproliferative granulomatosis with polyangiitis, which again, we're not really suspecting this because the symptoms are restricted mostly just to the kidney. And all of the lung symptoms that the patient is having is because of his malignancy, a right upper lobe density, and the fact that he's been smoking for so long, he's had a weight loss of 4 kg. We're suspecting that he has cancer. We're not suspecting any other sort of lesions. And so the answer here would be E, membranous nephropathy. Okay. Would you mind if we took a 5-minute break? Let's continue. So, oh yeah, for this question, just something that I would like to add, I guess, a little bit. Just another way to sort of look at the question would be to think of it as like, you know how everything in this question is sort of leading towards nephrotic? We know that granulomatosis with polyangiitis is a form of rapidly progressive or crescentic glomerulonephritis, and both of which are nephritic, right? So we're not really thinking of that. Membranoproliferative is also Oh, sorry. Membranoproliferative is mostly nephritic, but it might actually present as nephrotic. Um, Anyways, so yeah, so this is also where we're assuming that it would be nephritic. FSGS, yes, this is nephrotic. But FSGS would not show thickening of the basement membrane diffusely, right? They're going to say that it's segmental. And the fact that it isn't segmental, they're not mentioning it. We're assuming that it's global, it's more diffuse, and that just goes with membranous more than anything else. Okay, and that's sort of what the electron microscopy would look like. I feel like just give me 1 second. Could we stop recording just for 1 second? Okay, sorry, just 1 moment. Okay, sorry, my bad. So yeah, this is what this would look like on light microscopy. This is what the basement membrane would look like. You can see that they're thickened and it's diffusely thickened. This is pretty much one glomerulus, right? This entire thing, and it's diffusely thickened, and so that is why where we would not assume this is FSGS, we would assume that this is membranous, which would be more diffuse. All right, next question. A 7-year-old boy is brought to the physician by his mother for evaluation of progressively worsening swelling around his eyes. He has no history of major medical illnesses. He had a sore throat and a cough 2 weeks ago that resolved spontaneously. So immediately, what are we thinking? We're thinking post-strep, right? Okay. Physical examination shows moderate periorbital edema and 2+ pitting edema of the lower extremities. Kidney biopsy shows effacement of podocytes on electron microscopy. Now, the electron microscopy is showing a defect in the podocytes, which is not nephritic. So we're actually not thinking of post-strep anymore. What would you see on your analysis? The fact that it's a 7-year-old boy, the fact that he's coming with swelling, right? And we're seeing effacement of the podocytes on electron microscopy. This is more so giving us minimal change disease. And what would we see for minimal change disease? We would see fatty casts and albumins. So yeah, this was a little bit of a tricky question, but again, you need to make sure that the biopsy is going to be the one thing out of everything else that's most indicative of what actually it is, what the actual disease is. So the fact that the biopsy gives you effacement of podocytes means that we're definitely leaning towards MCD, and this is not nephritic anymore. Despite what history says, we're definitely going to go with what the biopsy says. So yeah, fatty cast and albumin, since this is MCD. And that's sort of what it looks like. This is light microscopy, actually. We're not going to be able to see a lot on light microscopy. For MCD, this is more so electron microscopy and not light. And that is why the glomerulus looks pretty much like in good condition overall, I would say. Which is what you're supposed to see in a patient who has minimal change disease. A 31-year-old man is brought to the emergency department because of weakness and abdominal pain for the past day. Since this morning, he has also had nausea and 2 episodes of vomiting. He has type 1 diabetes mellitus and hyperlipidemia. So type 1 diabetes, we're immediately thinking of, you and I know what we're thinking of. Let's keep it inside for till the end of the question. So current medications include insulin and atorvastatin, although he admits that he has not taken his medication for the past few days. He appears drowsy. His temperature is borderline elevated, not very high, but yeah, a little bit high. His pulse is really high. His respirations are elevated too. Blood pressure is a little bit on the lower side. Examination shows dry mucous membranes and decreased skin turgor. He has a fruity odor to his breath. This one line should pretty much tell you exactly what we're suspecting in this patient. There's epigastric tenderness with no guarding or no rebound. Bowel sounds are normal, and then this is what the laboratory investigation shows. Hemoglobin is fine. The leukocyte count is fine as well. Platelets are perfect. Sodium is good. Potassium is okay. Urea nitrogen, 15 to 20 is normal. The glucose is very, very elevated, and the creatinine is fine. So the fact that the glucose is super elevated, he is a type 1 diabetic. He admits that he has not taken his medication for the past few days. He's drowsy right now. Dry mucous membranes, fruity odor to his breath. All of this points towards, I want to hear you say it. Exactly. diabetic ketoacidosis. And we know that diabetic ketoacidosis is one of the mud piles things, right? It's the D in mud piles. And what is mud piles? High anion gap metabolic acidosis. So which one of these options is that? It's definitely not F, that is alkalosis, definitely not B, that's alkalosis as well, definitely not D. So let's look at the answer, and the answer is E. So 7.24, that goes with the pH, that goes with the metabolic acidosis picture. We have PCO2, which is lower, it's much lower than normal, which once again would go with the metabolic acidosis picture, because PCO2 being low would be the compensation, the respiratory compensation, right? It's towards the alkalotic side because we want to normalize the pH. This is the body's way of trying to normalize it. And then when we calculate the anion gap for this, sodium 135 minus hold on. 135 minus 98 minus 9 would be 28. So yeah, that's exactly what we want. We want to make sure that the anion gap is high because this is mud piles. And yeah, for the rest of the questions, I'm afraid you might need to calculate the anion gap. For this, PCO2 50 would not make sense, right? A higher PCO2 would not make sense. In this case, we're most likely thinking compensation and respiratory alkalosis. So the CO2 would need to be low. And yeah, E is the one that makes the most sense. Moving on, a 36-year-old man comes to the physician for a 4-week history of swollen legs. He has difficulty putting on his socks because of the swelling. 2 years ago, he was diagnosed with sleep apnea. He takes no medications. He emigrated from Guatemala with his family when he was a child. His BMI is high, very high. This his very high BMI sort of goes with the sleep apnea because obese patients usually have sleep apnea. His pulse is okay. His blood pressure is on the higher side. There is edema. A renal biopsy is obtained. Which of the following is the most likely to be seen under light microscopy for the patient's renal biopsy specimen? Let's look at the labs. The albumin 3.1 is low. The normal should be 3.5 to 5.5. Cholesterol 200 is the normal, and this is elevated, so yeah, cholesterol is high as well. There is a lot of protein in the blood, 4 plus, and numerous fatty acids. We're thinking nephrotic, right? So we're thinking nephrotic, and we're thinking, even from the patient's presentation, we're thinking nephrotic. Which one do you think out of all of these it is? That's actually A. Segmental sclerosis of the glomeruli. That's the one option that makes the most sense out of these. A lot of the other ones, eosinophilic nodules within the glomeruli, we're not really thinking of this. We're not really thinking of fibrin crescents within the glomerular space. That's more so nephritic. Um, diffuse thickening of the glomerular capillaries, amyloid deposition. Amyloid deposition would make sense. There's nothing going on that we're suspecting would go with amyloidosis, right? What are different conditions that would go with amyloidosis? Amyloidosis would be plasma cell dysplasia, so things like multiple myeloma, heavy chain diseases, for instance, and anything that would increase the amount of immunoglobulins in the blood, because those are what get deposited, right? So we don't have that. Any inflammatory conditions would cause amyloidosis. How? Because inflammatory conditions increase the serum, the SAA, which is the serum amyloid protein precursor. I think I forgot the full name for it, SAA, but it's basically an acute phase reactant, which means that acute phase reactant is something that's elevated in inflammation. And so we're not suspecting this in that case because he does not have any any indication. So FSGS is what makes the most sense here. Yeah, here we go. We have a picture of this. So we can sort of see that there's segmental sclerosis here. There's a little bit over here as well, but pretty much the majority of the glomerulus looks normal, other than like small sections of it. All right. A 44-year-old man comes to the physician because of a 2-week history of lower extremity swelling and frothy urine. Once again, what are we thinking? Nephrotic. He has a history of chronic hepatitis C. So what kind of nephrotic are we thinking of? Okay. Okay, I hope you said FSGS. Physical examination shows 3+ pitting edema of the lower legs and ankles. Further evaluation is most likely to show which of the following. So they're just pretty much asking what you would see in nephrotic. This is one of the easier kinds of questions that you can get. I think, yeah, this is a little bit easier than I think what you guys would most likely get, but yeah, increased lipoproteins, we know why. Next question. A 38-year-old woman comes to the physician because of a 5-week history of abdominal distension and swelling of the face and lower extremities. So we're suspecting ascites, right? Swelling of the face and lower extremities. Okay. Patient notes that during this period her urine has become frothy. Okay, we're thinking what now? We're thinking of nephrotic. She was diagnosed with Crohn's and has multiple flares treated with systemic corticosteroids. She was diagnosed at 22. She's 38. She's had it for 16 years, which is a long time. She smoked half a pack of cigarettes daily for the past 20 years. So what's her pack year history? 0.5 times 20, 10. So her pack year history or smoking pack year history would be 10 in this case. This is not relevant right now, but just one of the things that I think you should know about. She does not drink alcohol or use illicit drugs. Her blood pressure is 142 over 83, which is elevated. Her BMI is pretty much normal. Generalized pitting edema, ascites, hepatomegaly, splenomegaly. Albumin concentration is really low. 3.5 onwards is the proper limit. Total cholesterol is high. It's supposed to be lower than 200. So again, all of these go with nephrotic, right? 4+ proteinuria. Renal biopsy is most likely to show which of the following. Now, something that I want you to remember is the fact that she has Crohn's disease. She's had it for a while, which is an inflammatory bowel disease. So what are we expecting? What kind of nephrotic are we expecting in this patient? We're expecting C, mesangial deposits that exhibit apple green birefringence on polarized light microscopy. Why is that? The fact that the patient has inflammatory, sorry, one of the, oh my God, sorry. Yeah, so basically there's an inflammatory condition going on, which means that there's definitely going to be an increase in the amount of acute phase reactants in your blood, which one of the ones is serum amyloid protein. And when you have that, that puts you at an increased risk of developing amyloidosis. Not only will this get deposited in the kidneys, you can also expect deposits in other organs of the body. So yeah. We're not thinking of anything else pretty much because this is the only one that makes sense. The fact that there's IBD and there's nephrotic, there's the only two things that are given in the question. So you're supposed to look at which kinds of nephrotic would go with Crohn's. And amyloid nephropathy is the only one that would sort of go with that. Okay, let's go over the other questions briefly. Precenteric proliferation of the glomerular cells and linear intramembranous IgG deposits. The moment you really consider that, right? Thickened glomerular basement membrane on light microscopy and subepithelial dense deposits. This is membranous. Again, we're not really thinking of that. Oh, I hope you can hear me. Okay, I hope inshallah there's no issue with the audio. Let me just double check. Okay, awesome. There's no issue. So yeah. Eosinophilic nodular sclerosis within the glomeruli, we're not thinking that. We're not thinking of eosinophilic granulomatosis, right? We're not thinking of, we're also not thinking of Kimmel style Wilson nodules, which is in diabetic nephropathy. This patient does not have diabetes. Mesangial IgA immune complexes. We're not thinking of IgA nephropathy. There's none of the predisposing risk factors. And same for segmental sclerosis. That's not one of the ones that we're thinking of. And yeah, that's pretty much what it looks like. This is the apple green birefringence, which is so popularly known for amyloidosis. Okay, next question. 25-year-old man is brought to the physician because of fatigue, lethargy, and lower leg swelling for 2 weeks. He noticed that his urine appeared darker than usual, and for the past 2 days has passed only small amounts of urine. So there's oliguria, there is dark urine. We can assume that there's hematuria, and then there's a swelling as well. Temperature is normal, the pulse is okay, the respirations are okay, the blood pressure is really elevated. There's 2+ pretibial edema bilaterally. Renal biopsy shows crescent formation. So we're thinking crescenteric, okay, with extracapillary cellular proliferation. Which of the following is the most appropriate next step? If we were to quickly look at the labs, pretty much everything looks okay. The nitrogen is kind of elevated a little bit. The creatinine is a little bit high. Glucose is fine. There's blood, there's protein. And there's numerous RBC casts which are dysmorphic. So all of these things together is giving nephritic. And the fact that they said that there's crescent formation or crescenteric glomerulonephritis, we know that this is nephritic already. Which of the following is the most appropriate next step? And we're thinking E, methylprednisolone, immunosuppressive. So that's the first thing that we want to do here. We don't want to do plasmapheresis. That is only and only for good pasture. There's absolutely nothing wrong with this man's lungs. He's not coughing up blood. So we're not thinking plasmapheresis, right? Rituximab. Rituximab is one of the ones that can be given for MCD, one of the ones that can be given for nephrotic. Again, we're not really thinking of that here. Hemodialysis, lisinopril. No, the first step here would be methylprednisolone for us to administer steroids. Usually steroids, and this is one of the things that actually Dr. Khalid said too, 50% of the times the answer is gonna be steroids. So if you don't know anything at all, put steroid. But here that's the correct answer. For this patient now, 2-week history of cough, shortness of breath, several episodes of blood tinge sputum. Now, what's the first thought that we're thinking of here? I know you know it. I know you know it. Okay. He has a 3-month history of progressive fatigue. His temperature is okay. Pulse is fine. Respirations are fine. Blood pressure is elevated. It's super high. Pale conjunctiva, crackled, heard an auscultation. He started on prednisone, and cyclophosphamide, which of the following is the most appropriate next step? Let's quickly look at his urinalysis. There's blood, there's protein, there's RBCs. Oh, and it literally says here, anti-GBM antibodies are positive. So this patient has good pasture syndrome, right? We're thinking good pasture. He's coughing up blood. He has all of the different things here. He's already on prednisone, right? So prednisone is usually the first step. Steroids are usually the first step. What do we want to give after steroids? What's the next step? And this one is for good pasture specifically and good pasture alone, and you don't want to put this answer for any of the other ones. What's the answer? Plasmapheresis. So the entire pathophysiology of this disease is caused by the antibodies against the basement membrane, right? Collagen type 4. Once you do plasmapheresis, which is basically like you're taking out the blood, you're cleaning it, you're removing all the antibodies, and then you're putting it back in, that would pretty much solve this. That would cause it's not a permanent cure, of course, because you're gonna have to repeat this over and over. But once you've filtered out all of the antibodies that are causing the issues, the patient's symptoms are likely to get a lot better. Okay. 67-year-old man comes to the emergency department for evaluation of 2 episodes of red urine since this morning. He has no pain with urination. He reports lower back pain and fever. 6 months ago, he was diagnosed with osteoarthritis of the right knee, and he manages that with 1 to 2 tablets of ibuprofen per day. This was 6 months ago. And he's been taking NSAIDs every single day, which is NSAIDs every single day. You're definitely, if the moment that they say this, the question all of a sudden is all because of that NSAID. This would either be GI, this would be renal, whatever they tell you, is going to be because of the ibuprofen, because NSAIDs every single day is a lot, and it's bound to cause something. So he has smoked 1 pack of cigarettes daily for the last 45 years. He does not drink alcohol. His temperature is elevated. His blood pressure is on the higher side. Shows a faint, diffuse maculopapular rash and bilateral flank pain. The remainder of the examination shows no abnormalities. And this is what the urinalysis shows. So we have 3+ blood, 1+ protein. We have RBCs, casts are negative, and we have numerous eosinophils. Now, what are we thinking of when you know that there is a diffuse maculopapular rash and we have eosinophiluria, or we have eosinophils in your urine? What's the first thing that sort of comes to mind? And then the fact that he's been taking NSAIDs every single day. Acute tubular nephritis, tubular interstitial nephritis. That is the most important thing that you're supposed to know here. the rash, the eosinophils, and then the NSAIDs. This is very, very characteristic of interstitial nephritis. All right, next question. A 52-year-old woman comes to the physician because of intense retrosternal pain for the past 3 days. The pain is worse with breathing or coughing and improves when sitting upright. She also reports a mild fever and shortness of breath. She's been diagnosed with CKD, secondary to lupus 12 years ago, and has been on hemodialysis since then, but she has missed the last 2 appointments because of traveling. The fact that she has CKD, she's been on hemodialysis since the past 12 years, and she just hasn't had her sessions, her past 2 sessions. 100% her symptoms are because of that. But we want to know what is being caused by that, right? She underwent a percutaneous coronary intervention 8 months ago for an MI. She takes azathioprine after hemodialysis. Her temperature is a little bit elevated, nothing much. The pulse is high, blood pressure is kind of high, lungs are clear to auscultation. Cardiac examination reveals a high-pitched scratching sound that obscures both heart sounds. So what are we thinking here? We're thinking a cardiac abnormality here, right? The remainder of the examination is unremarkable. Cardiac enzyme levels are normal. Anti-DNA antibodies are within normal limits. X-ray shows nothing. The ECG shows Q waves. Which of the following is the most likely cause of these findings? Okay, somebody said F. Oh, yeah, you're right. It is F. Elevated serum levels of nitrogenous waste. So first of all, what do you think is happening in this question? She hasn't had dialysis for the past 2 sessions, okay? And we're assuming that the nitrogenous waste in her body have built up. The urea, the creatinine has built up. Now, the heart condition that she is presenting with, the fact that the pain is worse with breathing or coughing, so it's pleuritic in nature, it's improving while you sit upright, and the fact that there's high-pitched scratching sounds. All of these is pointing towards pericarditis. And we know that pericarditis can be caused by uremia. The moment that your urea levels are high in your blood, uremic pericarditis is one of the things that can sort of occur, right? The QLabs are because of her old MI, the MI she had 8 months ago. We're not gonna think about that too much. Low levels of thyroid hormone, no. The cardiac examination revealed a high-pitched scratching. It has to be something that's related to the pericarditis, right? Adverse effect of medication, no. Serositis, no. Infarction of the myocardial segment. ECG is only showing Q waves, and that would be because of the old MI. There's no ST segment elevation. Purulent exudate, we're not thinking infectious, right? For the pericarditis, we're thinking uremic. And that is why elevated levels of urea is going to cause the pericarditis. A 6-year-old girl is brought to the physician because of increased swelling around her eyes. Her vital signs are within normal limits. Physical examination shows periorbital edema, abdominal distension with shifting dullness. What is shifting dullness? Immediately we're thinking ascites, right? So she has ascites. She's 6 years old. So this is a pediatric patient. She has increased swelling around her eyes, right? Albumin is 2, which is less. Cholesterol is 290, which is high. Your analysis shows proteinuria and fatty casts. All right. Which of the following is the most likely kidney biopsy specimen? So a 6-year-old girl with nephrotic syndrome, what are we thinking of? Minimal change disease. What do we see on minimal change disease? Do we see effacement of the food processes on LM? No. Subepithelial dense deposits on light microscopy? No. No, we don't. Deposits of IgG C3 at the glomerular basement membrane? Mesangial proliferation? No, that's more so IgA, right? Granular subepithelial deposits of IgG, IgM, C3 on immunofluorescence? No. Right. We don't see that, right? Effacement of food processes of podocytes on light microscopy would more so be FSGS. And then the dense deposits, the subepithelial dense deposits, or also known as a spiky or a lumpy or a hump sort of appearance, would be membranous glomerulonephritis. In this case, we would have normal glomeruli on light microscopy. So we're not expected to see anything on light microscopy. We will, however, see effacement on electron microscopy. Okay, next question. A 40-year-old woman comes to the physician because of a 1-week history of fatigue, dark urine, and a feeling of heaviness in her legs. 2 weeks ago, she returned from a vacation in Brazil where she spent most of her days exploring the city on foot. She gained 3 kgs. So the fact that we have dark urine, we have heaviness of the legs, and then we have the weight gain. So there's some sort of edema going on, there's fatigue, there's dark urine, and she has SLE. Her only medication is hydroxychloroquine. Her temperature is normal, her pulse is okay, her blood pressure is very high. 2 plus pretibial edema. If we look at the urinalysis, it has 3 plus blood, 1 plus protein. Yeah, this is pretty much giving us a picture of nephritic syndrome. Which of the following is the most likely cause of the patient's leg findings? So why do you think that there is edema in this patient? What do you think causes edema? Why do you think there's edema in a patient with nephritic syndrome? Renal protein loss wouldn't be right because that's mostly nephrotic, right? Venous insufficiency, lymphatic obstruction, increased capillary permeability. There's nothing that points towards these. There's no infection that she has. Yes, she came back from vacation, and one of the first things that you could think of could be infection, but she never had a spike in her fever. All of her vitals, everything is normal, and so we're mostly thinking of salt retention. Right? Now, for all of these questions, I've given the explanation in the description right here. Sorry, right here. So yeah, so we were thinking nephritic, right? Nephritic is the most important one where you have red urine, a little bit of proteinuria, but not too much, right? And lupus. Lupus gives us nephritis, most likely. Yeah, so this is pretty much the explanation. What ends up happening is that the filtration barrier. Remember how we talked about earlier for nephritic that the filtration barrier is affected or is depleted? What ends up happening is that the GFR goes low, and we talked about that as well. When the GFR is low, not a lot of salt and water are able to leave. And so most of it gets retained in the body. And when the water gets retained, the salt gets retained, you're obviously going to have edema. And if you'd like the explanation to any of the previous questions, they're also in the description of the presentation. Okay. A 24-year-old man comes to the emergency department because of a progressive shortness of breath and intermittent cough with blood-tinged sputum. During this time, he had 3 episodes of blood in his urine. So he's having bloody sputum or hemoptysis, and he's having hematuria. These 2 things together, I think we sort of already know where this is going. 6 years ago, he was diagnosed with latent TB after a positive routine tuberculin skin test, and he was treated accordingly. His maternal aunt has SLE. The patient does not take any medications. Temperature is okay. Pulse is okay. Respirations are fine too, and the blood pressure is slightly elevated. Sorry. Diffuse crackles are heard at both of the lung bases. The chest X-ray, laboratory studies show this. So the creatinine is high, the urea is high. Numerous WBC casts, RBC casts. What are we thinking? We're immediately thinking nephritic from this analysis alone, right? Renal biopsy shows linear deposits of IgG along the basement membrane. Which of the following is the most likely diagnosis? So we have nephritic, very obviously, from the urinalysis. From the question, it looks like nephritic as well. And then I think the one thing that was, the takeaway from this entire question has to be the linear deposits of IgG. And there's only one thing that can have linear deposits, and that is Goodpasture syndrome. So yeah, we're not thinking reactivated TB, mostly because the urinalysis is giving us a perfect picture of nephritic, right? We're not thinking that. IgA, there are none of the predisposing factors for IgA. We're not thinking that either. For eosinophilic, they would definitely give you either an increased IgE level, they would give you maybe something related with P-ANCA, they might give you, asthma or sinusitis or any of the other sort of conditions. For granulomatosis with polyangiitis, again, for both of these, they might actually tell you about granuloma formation as well. There's no other respiratory tract infection symptoms, I would say, so not this either. Not really microscopic. We're not thinking that. And then lupus nephritis. Yes, his aunt was diagnosed with SLE, but there's no signs or symptoms of SLE for this patient. So we're not thinking that. And good pasture makes perfect sense. Oh no. No, you guys have the answer. Okay, we're just gonna go with it. A 63-year-old man comes to the emergency department because of a one-day history of shortness of breath. He has decreased urine output. 3 weeks ago, he had a sore throat. It was treated with over-the-counter gargles and licorice. That is weird. He has type 2 diabetes mellitus. His only current medications are metformin. Blood pressure is really high. There's diffuse crackles. Okay, 2 plus edema. Creatinine is elevated, urea is elevated. Oh, positive anti-streptolysin O antibody titers. There you go. We pretty much need the entire rest of the question doesn't make we don't need it basically. The only thing that we truly needed was this positive anti-strep O antibody titers. The patient's urinalysis is most likely to show which of the following findings. We're thinking post-strep glomerulonephritis. That goes with 1 plus proteinuria, lots of RBCs, the highest out of all of these, right? WBCs were not really, doesn't really matter to be honest, but the cast has to be RBC. So D is the only right answer. And this is what it sort of looks like. I think this is a fatty cast. I don't think this is an RBC cast. So we're just gonna ignore this picture for now, and I'm gonna come back to this later, but don't and for your exam, I would highly recommend that you guys go over what casts are supposed to look like, because sometimes the scenario itself can look a little bit ambiguous. You're not really sure what's going on, but sometimes the cast itself can be very, very characteristic for whatever disease you're talking about. And so I would definitely go over those. A 40-year-old man comes to the emergency department because of difficulty walking for the past 4 hours. She first noticed her symptoms after getting up in the morning, and she was dragging her right foot while walking. She seems tired. She has a history of chronic sinusitis. Interesting. 6 months ago, she was diagnosed with asthma. So asthma and sinusitis. Her medications include blah, blah, blah. Her temperature is elevated. The pulse is okay. Blood pressure is elevated as well. Auscultation shows diffuse wheezing over bilateral lung fields because of her asthma, I'm assuming. Tender subcutaneous nodules on the extensor surfaces of the elbow. Palpable erythematous lesions on the shins. Dorsiflexion is impaired. Sensation to pinprick. Light touch vibration is decreased. Laboratory studies show the following. So what do they show? Urinalysis shows 2 plus blood, 3 plus protein. We're thinking nephritic, right? Most likely this could be nephritic. Serum, urea, and creatinine both are slightly elevated. The platelets are fine. Hemoglobin is fine. Leukocyte count is very, very elevated. The normal limit, upper limit would be 11,000. This is 24,000. And out of those, we see eosinophils are 29%. The normal eosinophil percentage is 0 to 1%. Highly, highly elevated eosinophils. So what are we thinking? That is right. We are thinking of eosinophilic granulomatosis with polyangiitis. So the fact that this is nephritic, right? The fact that there is eosinophilia, right? The fact that you have palpable purpura, you have those lesions, the chronic sinusitis, and then the asthma. All of these point towards eosinophilic granulomatosis. Okay, this is just a small sort of overview for you guys. I really like how everything is concise in one table, and they have management as well, which I know is very important for you guys. So I would recommend that you guys pause for a second, quickly go over these in your own free time, as it's very helpful. All right, we're almost done. So a 22-year-old man comes to the emergency department because of a 1-week history of dyspnea and hemoptysis. He has no known sick contacts. There is no personal or family history of a serious illness. He takes no medications. His temperature is normal, pulse is okay, respirations are okay, blood pressure is very high. Examination shows inspiratory crackles at both the lung bases. Usually when they talk about lung bases specifically, they are talking about fluid overload. So inspiratory crackles at the lung bases, usually whenever there's fluid overload, there's pulmonary edema, congestive heart failure, those kind of stuff, there would be crackles here. Not always, those aren't the only conditions that cause it, but this is just in general. Whenever you see the word lung bases, think about that. Remainder of the examination shows no abnormalities. The hemoglobin is okay. The leukocyte count is all right. The platelet count is okay as well. Urinalysis shows 2 plus proteinuria, 70 RBCs, and 1 to 2 WBCs. Chest X-ray shows pulmonary infiltrates. Further evaluation is most likely to show which of the following. So the fact that 2 plus proteinuria, 70 RBCs, we're thinking nephritic, right? There's pulmonary infiltrates. There's hemoptysis. There we go. Anti-GBM. That's the only thing that makes sense here. There's nothing that would say P-ANCA, C-ANCA, nothing about SLE. This would not be membranous either. They'd most likely give you a renal biopsy in that case, and IgA just no. That wouldn't make sense either. Okay. A 53-year-old man comes to the emergency department because of a 1-month history of cough, productive of small amounts of blood-tinged sputum. In this time, he developed fatigue, myalgia, shortness of breath on exertion. He's had a 2 kg weight loss over the past 2 months. Whenever they talk about weight loss, our first thought has to be malignancy, right? He has no personal history of serious illness. His mother had SLE. His temperature is okay. Pulse is sort of okay. Respirations are all right as well. Blood pressure is quite high. Diffuse bronchi are heard on auscultation. There's multiple palpable erythematous lesions on the lower extremities. So this has to be a kind of vasculitis, right? Laboratory study shows the following. Leukocyte is all right. Platelet is okay. ESR. So there's some sort of inflammation going on, right? Creatinine is 2.1, which is twice the normal amount. ANA 1 to 40. So ANA is elevated as well. There is proteinuria, there's hematuria, and numerous red blood cell casts. Further evaluation is most likely to show which of the following. We are seeing D, myeloperoxidase anti-neutrophil cytoplasmic antibodies. That's basically MPO or basically P-ANCA. Now, which disease has P-ANCA elevated? Two of them too. So there's eosinophilic granulomatosis, right? And then there's microscopic polyangiitis. What do we think is, which one of these do we think is in this patient? So we're definitely not thinking eosinophilic. We because there's no asthma, there's no, chronic sinusitis, there really isn't anything that's sort of giving us granuloma formation. I think more likely what we're thinking of. Oh, it literally says without granuloma formation. There we go. This is 100% microscopic polyangiitis. So yeah, we're definitely not thinking E, right? We're not thinking C, SLE, because of the fact that they've said no granulomas. Definitely not anti-GBM. There's no hemop. Actually, there is a little bit of hemoptysis, but yeah. So, anti-GBM, they would say something like linear deposits or something. The fact that they really say that there's no granuloma is pretty much, I would say, I would go with D for that, honestly. And there's purpura. There's purpura. And the good pasture syndrome would not have purpura. Neither would, a lot of other ones. All right. 68-year-old man is admitted to the ICU after open abdominal aortic aneurysm repair. The patient has received 4 units of packed RBCs during the surgery. During the first 24 hours of the procedure, he only passed 200 ml of urine. So that's very, very low. The normal amount of urine would be anywhere from like 1 to 2 liters, and 200 ml would be very less. He has congestive heart failure and hypertension. Current medications include atenolol and enalapril, spironolactone, blah, 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 whatever. He appears ill. His temperature is okay. His pulse is slightly elevated. His respirations are okay as well. Blood pressure is fine. There's dry mucous membranes and flat neck veins. The remainder of the examination shows no abnormalities. Serum creatinine is elevated. BUN is super elevated, right? His and BUN at the time of admission were these. Which of the following, further evaluation is most likely to show which of the following features in this patient. So what are we thinking? we're thinking of the fact that he received 4 units of flagged RBCs means that he lost a lot of blood in the middle of his procedure, right? That, what do you think can happen then? Hypoxia, right? Hypoxia can happen, hypovolemia could happen, and he's only passed a small amount of urine, which furthers our differential of hypovolemia, right? Flat neck veins, dry mucous membranes. The fact that so we're thinking most likely of an AKI, in specific, especially with oliguria, we're thinking AKI. Now, what kind of AKI could this be? Could this be pre-renal, intrinsic, or post-renal? For this, the number one thing you need to look at would be the urea to creatinine ratio. So for that, you want to divide 48 by 2. The answer would be 24. Anything that's over 20 has to be 100% has to be pre-renal azotemia. So pre-renal azotemia we know is caused by hypovolemia, which pretty much goes with all of the other parts of the question. So the fact that there's oliguria, the fact that there's flat neck veins, whatever, all of these things. And so what do you think would be the answer? Low urine sodium. So when you have hypovolemia, your body is trying to absorb as much sodium as possible to be able to absorb water into the body because we have hypovolemia. Makes sense, right? And so the amount of serum, the amount of urine that's excreted, or the FeNA, the fractional excretion of the fractional excretion of sodium, sorry, would be very low. That pretty much goes with D. The urine osmolarity would actually be very, very high because you're reabsorbing all of the water, right? If your body senses that there's less, if the volume of blood is low, they would reabsorb more water. And so when you're reabsorbing all of the water, all of the electrolytes get left behind in the urine. And so the osmolarity or the concentration is very high. We're not expecting leukocyte casts, that would more so be pyelonephritis, that would be UTI. We're not expecting hematuria, that is more so nephritic syndrome, and proteinuria is nephrotic. We're not expecting that, honestly. Oh, that's weird. Oopsies, sorry. So, a 68-year-old man comes to the physician for a follow-up examination. He has type 2 diabetes, hypertension, CKD. Medications include all of the following. Physical examination shows pitting edema of the ankles, and the creatinine concentration is 4.5. Which of the following sets of serum findings is most likely in this patient? So they've mentioned that he has CKD, right? His serum creatinine concentration is 4.5, and around 1 to 1.2 is the upper limit of creatinine. 4.5 is obviously very elevated. So what are we thinking? In a patient with CKD, which of the following makes the most sense? Let's start off by vitamin D, because I feel like that sort of is the first thing that gets impacted. When you have CKD, your 1-alpha hydroxylase enzyme is not really working as well, so your vitamin D is not going to get activated. You're not going to have the active form. You're not going to have 125 dicholecalciferol. You're probably just going to have the unactivated version. So your vitamin D would be decreased. Immediately, we rule out A. So it's either B, C, D, or E. When vitamin D is decreased, what happens to calcium? Vitamin D is responsible for reabsorbing calcium from the GI. When the vitamin D is less, the calcium has to be decreased as well. We're ruling out C. So it's either B, D, or E. Right? When calcium is less, PTH is high. Right? The PTH has to go up. So now we're ruling out E as well. So it's either B or it's either B or D. The difference between the two is phosphorus. What happens to phosphorus in the event that PTH goes high? PTH is responsible for trying to increase the amount of calcium, trying to decrease the amount of, no, but hold on. Oh, right, phosphorus. The actual explanation for phosphorus would be that the kidneys aren't working properly, so the kidneys are not able to excrete phosphorus as much and not able to reabsorb calcium as much. So the answer would be B. A vitamin D would be decreased, right? When the vitamin D is less, the calcium is less, and calcium is also less because your nephrons are not working properly to be able to reabsorb. They're not able to excrete as much or secrete as much phosphorus, and then all of these things would lead to an increase in the amount of PTH. Ooh, that pretty much was my last question. This is just sort of a QR code that you can scan to evaluate the session. You can tell me if there's anything you didn't like or if there's anything you liked. I would love to hear your feedback. Um, if you're interested in where the questions were from, they're pretty much all from Ambos, with one or two from UWorld. But yeah, Ambos is my primary resource, and I specifically used the step 2 filter for you guys because that's what third year is more so focused about, right? I really, really hope that, inshallah, this session was beneficial for you guys. I really hope that I covered the majority of the points in the lectures. I would highly recommend that you go over Dr. Khalid's transcriptions because, again, he does mention where exactly you need to focus on, what exactly is the most important part of the lecture, and I would recommend that you definitely do his transcriptions. And yeah, that's pretty much it. I'm really glad you guys have this because I know in my time we didn't, and his lectures were one of the most confusing ones out of honestly any other block. But that's just him. That's just who he is. But yeah, that's it from my side. If you guys have any other, concerns, any feedback, any questions, anything at all, please let me know. I've linked my phone number and email address in the beginning, and this is the QR code to evaluate the session. That's it from my side. Thank you so much, and I hope, inshallah, that you guys ace the exam.